So, quality assurance in surgical oncology. Surgical oncology obviously has a number of main tasks. We should, in the multidisciplinary care, with the medical oncologists and radiation oncologists, have commitment, competence, and continuity. We should know what the other disciplines can and cannot do. But in addition to the other disciplines, we should have skills. We have to be aware of the I can do that too syndrome. And in our multidisciplinary meetings, decisions are more important than incisions. And all our results should be used and be regarded and be discussed on the basis of outcome. And that is quality assurance. An example, British Medical Journal, McArdle, 1991. 13 consultant surgeons in rectal cancer with a variability not in case mix, but in curative resection rate, leakage rate, post-op mortality, local recurrence, and survival. And his conclusion was that some surgeons perform less than optimal surgery, some are less competent technically than their colleagues, and some fail to supervise surgeons in training adequately. If by more meticulous attention to detail the results of surgery could be improved, and our results suggest that this would not be difficult, the impact on survival might be greater than that of any of the adjuvant therapies currently under study, and that's still true. So what is quality assurance? The complete set of systematic actions that is required to achieve a treatment result that meets a certain standard. And a lot of surgeons think this is very difficult for surgery. For a working definition is, of course, to have the right patient, getting the right operation in the right setting, while minimizing complications and register morbidity and mortality, maximizing effectiveness, and looking also at patient satisfaction, which is rarely considered. Obviously, we are working in a team, and surgical oncology is top-class sport. We need to train adequately and also multidisciplinary, and we need to evaluate our patients pre- and post-operatively in a multidisciplinary team effort. And then, indeed, we can win our goal and cure the patient. As I indicated, two facts about cancer surgery. Complications are common, and the chance of complications is dependent where and by whom the surgery is performed. There are two ways to improve surgical outcome. Of course, direct patients to the best places, the centers of excellence, but the major impact is by improved care by everyone, and that is really quality improvement. On the one hand, off-the-shelf process improvement, making good guidelines and stick to those guidelines, but more important is outcome-based quality improvement. I mentioned already the D1 and D2 trial, but also the Dutch TME study was a fact. I mentioned in the D1 trial, the first, I think, real study with such a quality control, protocol book, surgical guide, videotape, and preoperative guidelines, and feedback to the different people. And I showed you that this had an effect in survival in the Netherlands. Just a comparative series, there is one hospital in the Netherlands, the National Cancer Institute, which performs an adequate D1 dissection and post-operative radiochemotherapy, and you can see the time to local recurrence on the right side. With D2 versus chemoradiation therapy, it is the same, whereas overall survival is not significantly different. So the conclusion at this moment, we have the ongoing running trial, is that adjuvant chemotherapy has survival recurrence benefit over D1, but not over D2 surgery, although there is a Korean study indicating also a benefit. But I will focus more on rectal cancer. When we saw in our database, both from Norway and the Netherlands, the recurrence rate 15 years ago up to 40% after rectal cancer treatment. We have to consider that in the literature, definitions for rectal cancer are unclear, definition of local recurrences are unclear, a lot of variability, but there were some standards. Warren Anker, Memorial Sloan Kettering, Moria National Cancer Center Hospital, and Heald having way less local recurrence rate. So we considered there were outdated surgical techniques, no blunt dissection. A lot of surgeons in the Netherlands, including my own, had learned rectal cancer surgery that way. No coning, no shake hands with the more common abdominal perineal resection, but TME surgery. And TME surgery in non-randomized trials indicated some 10% local recurrence rate, whereas in non-standardized trials it was 29%. The TME trial defined all the aspects and the role of everyone. You had to perform a number of operations under supervision, both by an expert surgeon as well as a pathologist. And we evaluated radiation therapy, short-term radiation therapy, 5x5 gray, with standardized TME alone, and also standardized pathology reporting. We had quality control of radiation therapy, surgery, and pathology. In the Netherlands, we had roughly 10 different radiation therapy schemes at that time, and they were all post-operatively. Also, the pathologists were trained. It was not allowed anymore at the operating table to open the specimen. No, the specimen had to present it fresh, was photographed, was sliced, was inked, and then examined how the surgeon had performed, with a special attention to the circumferential margin. So fortunately, I built that with this first gastric study. I have a data center in my center controlling again 80 hospitals performing this study. And we had a lot of feedback to local surgeons, but also to local pathologists, instructor surgeons, review committees, etc. And that ran for 3 years. A lot of surgeons thought this supervision in the operating theater would not work. But it went so well that you had to perform 5 operations under supervision, that at the end of the trial, 1 out of 5 operations in the Netherlands was still performed with an outside surgeon who did not only instruct to do the proper resection, but also the reconstruction. So that changed the role of APR dramatically. We went from 47% to 27% APRs. These were the initial results published. Local recurrence was significantly reduced by radiation therapy as opposed to TME alone. Majority of surgeons in the Netherlands thought that with proper TME surgery we could make radiation therapy redundant. The contrary was true. The better the surgery, the more beneficial effect of radiation therapy. When circumferential margins were positive, the radiation therapy did not make a change in local recurrence rates. So also here we made a change, dramatic change in the recurrence rate, not only within the study but also outside the study. Contrary to the Swedish trial, because in the Swedish trial there was not standardized surgery, they had 27% local recurrence rate versus 12% local recurrence rate with surgery alone versus radiation therapy. We reduced that, and they had a survival benefit of 10% as a result of radiation therapy with that high local recurrence rate. We couldn't prove it at this moment in time. We are currently evaluating 10-year results that might show a difference, but so far we did not see a difference. Here you can see the relation of the quality of resection and the circumferential margin. When the circumferential margin was more than a centimeter, and that's very good, the majority had a complete TME specimen. When the circumferential margin was positive, so less than 1 millimeter, there was a very high rate of incomplete TME specimens, which were just evaluated also macroscopically by the pathologist. Another thing, because of this increased control, is when we look at a Swedish rectal cancer trial, which is in blue, and in pink the TME trial, you see at 4-5 centimeters, the majority in Sweden still got an APR, whereas in the Netherlands we are at a little over 20%. So the training and supervision changed that practice also a lot. When our results were published here and for the first time presented, it also had perhaps an effect on the recently published CRO7 study from the UK, published by Phil Quirk in The Lancet in 2009, so that the percentage of positive circumferential margins thereafter significantly was lowered, and this has a major impact on local recurrence. So trials have a large educational effect because of all the controls, But also in the Netherlands, the trial stopped, and finances to control that style stopped. And in certain regions, unfortunately, circumferential margin reporting by pathologists dropped to 50%. The problem is that only around 1% of patients, like in Western Europe, are enrolled in clinical trials, especially also in EORTC studies. EORTC rectal cancer trial ran for 10 years, accruing 1,000 patients. So these were highly selected patients. Also in the TME trial, like in the gastric, we did not have an age limit. Here you see the three trials, the TME trial, the Swedish rectal cancer trial, and the MRC trial in comparison. You can see Swedish rectal cancer trial, the differences are all significant, from 6 to 10 centimeters in favor of radiation therapy, but Swedish rectal cancer trial had 26%, TME 15%, and the MRC had 10%. We have to consider that not in the Dutch trial did we standardize preoperative imaging. That was more or less standardized in the 07 study, especially by preoperative MRI. But still, interesting differences are found in the more proximal tumors, more than 10 centimeters, 12% local recurrence rate in the Swedish, 6 in the TME, which is similar in the 07, but we have an insignificant difference with radiation therapy, so that many surgeons think above 10 centimeters do not give radiation therapy, because we published extensively about the long-term effects of radiation therapy in terms of bladder complications, which is now in the European Journal of Cancer, the defecation disorders, which was significantly worse in those with rectal cancer and radiation therapy. So these differences should be evaluated further. Another thing, the so-called Eurocare study looks at cancer registrations throughout Europe, and there are major differences observed in Europe in the outcome of colon and rectal cancer, by more than 10%. So therefore, we think that it is very important to have nationwide audit programs, especially for rectal cancer. And there are already a number in existence. Norway started the first in 1993, Sweden followed, Denmark, the UK, Belgium had a program, and the Netherlands. We have now all our operations on colorectal cancer are since January 1st registered. It's an official by the government and authorities quality measure to have yourself registered. So it is necessary. It's also connected with the payment by the insurance companies. When you do not fill in the form by internet, you cannot declare that. Nationwide training products have an effect, as has been described by Arne Wiebe, on local recurrence rate and overall survival. Here you can see that more graphically, from 86 to 88 and from 94 to 99, local recurrence and 5-year survival improved by just better structurization of the process of the treatment and of the surgical quality and pathological examination. Also, Lars Palman published in the European Journal of Surgical Oncology in 2005 a special issue on quality assurance that mortality went down. There was more supervision also on anastomotic dehiscence and actions taken for that. 5-year local recurrence rate was below 10%, 5-year relative survival 60%. And what has been observed now, both in the Netherlands, not yet published, Sweden, Norway, and also now in the UK by Phil Quirk, is that rectal cancer has now a better 5-year survival than colon cancer, because all the attention was focused on rectal cancer. Colon cancer was everyone's operation. So we have to focus now on colon cancer treatment as well. Another thing which comes from many registers, but also the Swedish Cancer Registry, the impact on hospital volume on outcome of rectal cancer surgery. When less than 25 operations were performed, the operative mortality was increased by 4-fold. And of course, it's not the aim to have an outcome registry of naming and shaming and blaming. No, the idea is to give feedback to the surgeon, to the hospitals, give indications that they are underperforming and that other hospitals are performing, and that you provide services to increase the performance. And of course, on the very long term, there should be other implications, like sending these results to the board of directors of the hospital. So I founded with a number of other surgeons the Dutch Surgical Colorectal Audit Foundation, where we assess the structure and process of care, outcome tracking to confirm improvements, hospital, surgeon, and per patient. And we give feedback after half a year, after a year, to all the individual surgeons and to the hospitals, that we use the real data, and we also try to compare that now with outside data. So we're structuring now the European national audit programs for rectal cancer, the programs I just mentioned. You can see there's also quite some difference in 30-day mortality, so we also have a focus on the attention endostomachic leakage gets and having protocols for that. And also looking at a template, what is the real essence of registration thing? We should not register to have more bureaucratic work, but having really the essence without too much burden to the surgeons. So all the audit programs so far give positive results. They are very cost effective. There have been calculations that in Norway a life saved is quite cheap. It only costs 700 euros by having more attention to quality, but there's still variation between European countries. Also, we look, and we have now a database of all the European cancer trials to look at all the variability in that. And we have the 07 UK data pending, the Swedish, the Dutch, the German, the EURTC, and the Polish rectal cancer trial. And some things come out, but have not been published yet, which are also very interesting. Here you can see when we skip post-operative mortality as a result of leakage, that when you have leakage and you survive the operation, long-term results indicate higher recurrence rate of cancer in those who have leaked. So leakage is still a very important surgical complication that should be dealt with and should be registered well. And there are certain hospitals who have 3 times the number of leaks than others, so we should intervene in that. So we are setting up an outcome-based quality improvement registry, looking at concurrent assessments of structure and progress of care, registry-based, eventually also some site visits, analysis aimed at identifying best practices, broad implementation of such practices, and outcome tracking to confirm improvements. So we are currently under development a European audit for colorectal cancer treatment using all the databases of all those countries. And we call this the European Audit for Surgical Oncology as an ESSO initiative. But we have other partners, also the ESTRO is funding it, and because they want to control the adequacy of the radiation therapy. The EURTC is giving their facilities as a data center, and this is under the supervision of the ECHO organization, the European Cancer Organization. So the vision is a multidisciplinary European registration structure of patient, tumor, and treatment characteristics linked to outcome registration, benchmarking and internal feedback among participants, continuous improvement in quality and efficiency of cancer care. And the start is with colorectal cancer, but obviously this also applies for breast cancer and eventually all solid tumor types. We have a steering committee, a multidisciplinary steering committee to look at all the databases, and we are just combining the databases right now. Obviously, the future is after the 2 years of registration and combining the databases to make it available to other countries. And this will be the true promise. Promise is a data management system where you can log in. It's web-based. There is the European bone marrow transplant, but also Eurotransplant uses this, this continuous statistical analysis is possible. You can continually compare your data with the data of others. So far, we have the partners of Norway, Sweden, Denmark, UK, the Netherlands, and Belgium in this combined structure. but we are seeking support from other countries. We're also supplying a grant proposal this year to the 7th framework of the European Commission to have other countries financially supported to help to set this up. And as an individual surgeon, you can also enlist and put your patients in the database and compare your results with the results of others. Therefore, setting this up in colorectal cancer as a goal of ESSO together with the other societies, but therefore thereafter also providing a template for other cancers. Thank you again for your attention.